That's a really good question. Many of our patients are coming forward using or seeking to use cannabis for symptoms related to the cancer or symptoms related to the cancer treatment. Chemotherapy-induced nausea and vomiting is a classic one that many of our patients have had difficulty with. Sometimes they're wanting to help out with pain that might be due to the cancer or due to our treatments. Some of them are looking just for sleep. Many people who have had either anxiety or distress around their cancer, they would like something for sleep, but they don't necessarily want to use a benzodiazepine or other sleep aids that are prescribed. We also know that there are a number of patients who come forward after advice from others or elsewhere looking to treat their cancer. They want an aid to treat their cancer. They may feel either the chemotherapy isn't strong enough on its own, they want other help, or some do feel that the cannabis can do the job on its own. There hasn't been a lot of research about that, and I think we'll discuss that a little bit later. But certainly we have a good discussion about the appropriateness of the use of cannabis products.
You know, I think that that it's important that when you're starting to work with a patient who comes to with cancers, that you identify with them immediately what their objective is, and including cannabis into their protocol. Because, you know, as practitioners, it's easy to make the assumption that, oh, I see you're having sleep issues, so I'm going to give you this for sleep. Or, oh, you have breast cancer that has been very responsive to this, I'm going to give you a therapeutic dose for apoptosis, killing the cancer, when the person just wants to have an appetite or whatever it is. So it also, not only does it help to identify the dosing levels, but also the types of cannabinoids and the profiles of the medicines themselves that'll differ considerably based upon the objective of the patient.
I agree totally. When a patient is referred to me, I ask them what they're hoping to achieve by taking cannabis. I ask them if they have ever smoked cannabis, because many people are very afraid of it, especially older people who are conservatively minded, and it still smacks of the Cheech and Chong thing. So I never address anything like that. I always talk about cannabis, medicinal cannabis, not marijuana, but I need to know how familiar they are with it. And as Mara said, you could be doing a whole big presentation when they just don't want to be sick to their stomach. So you have to know what their goal is. And then you can start steering after that.
You know, and interestingly, oftentimes somebody will come to us. I mean, we've treated thousands and thousands of cancer patients over the years, and somebody will come to us with a very specific objective that they're trying to accomplish. But then they start seeing, wow, my tumor's shrinking and it wasn't shrinking before. Let's maybe up this and see if where we can go with it. So, you know, it's important to keep checking in with them to make sure that you're staying consistently on their objective.
And those objectives will change over the trajectory of their disease course.
Correct.
You know, if you're looking at a patient who is receiving adjuvant treatment of one sort or another, they just want to be able to say that they've done their best to keep the cancer under control, it's cured, you know, that sort of thing. As people have more advanced cancer, there may be more problems with other symptoms, nausea, vomiting, poor appetite, pain. And then as they feed into, or as they transition into the palliative phase of their disease, they might need that for something very different. You know, they might want to be more awake, or they might want to have more sleep, you know, depending upon where they're at with their feelings, with their symptoms and such. And also, it's really good to have family input as well, because the patient may have one view and the family may have something different. And we're trying to find something that'll work for both of them, whether it be a dosing protocol or a component protocol that would work.
Well, I'll start out with how we approach it. And then I'm very interested to hear. We prefer a sublingual application. Obviously, it depends on what kind of cancer it is, you know, whether it's going to be like, for example, if it's somebody with cervical cancer, we may also have a vaginal suppository in conjunction or something like that. But the true dosing of that we're looking at, we do sublingually. We do that for a number of reasons. We believe that traditionally physicians prefer something that they can dose very specifically down to the single or even 1/3 of a milligram. And you can do that very well when 1 drop equals 1 milligram or 1 drop equals 1/3 of a milligram or something like that. It's much, much easier to get the dosing correct. Also, the bioavailability is more predictable. You know, maybe you don't get a certain percentage of it because of, you know, going through your digestive, but enough of it goes through the mucosal that you're going to be able to predict how long it's going to take effect and what that effect's going to be consistently. Whereas with an edible, it's all over the place. It depends on when's the last time you ate, how hydrated are you, what kind of mood you're in, how rested you are, what were the other ingredients within the edible. I mean, you can take the same edible 3 different times and have 3 completely different responses. And through the buccal or sublingual, we find that it's far more consistent. As far as the question about the strains and all that, I mean, I love Daeninck. I think he's lovely, and I think he's very bright. I think he's also extremely ambitious, and I think that the work being done where you're matching one strain to one cancer type is a bit of a party trick, you know, in a laboratory. That might be lovely and isn't that great, but I don't think that's the way it works in the real world. We do know that certain terpene profiles are more comfortable for patients as they get to higher doses. Obviously, you have to do some information about the patient themselves to see whether they're going to be somebody that's going to respond positively to something with a high alpha-pinene, where you may have somebody else who responds very well to a high linalool. I find that when treating cancer specifically, I always talk about the purples, but using these, you know, these more somnolent, you know, profiles of the medicine tend to be the ones that do the better job. And I think part of the reason for that is because you can get them to a higher dose without making them paranoid or feel like they're jumping out of their skin or having anxiety. You know, cannabis is biphasic, maybe even triphasic. And you could be trying to relieve somebody's anxiety and give them a dose that makes them anxious. You could be trying to get rid of their nausea and give them a dose that makes them nauseated. So it's very important that you find the sweet spot in using profiles of medicine over time. We've learned that those tend to be more of what I call the purples, which are the traditionally broadleaf. They contain more of the myrcene, linalool, those profiles. And that's not to say that, you know, my sister right now is going through chemotherapy and she gets very, very nauseated. I found her she's in Arizona, so it's out of my hands. I can't, you know, I've got her, I don't know how the medicine got there, but she's got some of my medicine for the treatment of the cancer. But the side effects of the chemotherapy themselves, right at the beginning, she couldn't handle the sublingual. It was nauseating her. So she couldn't even get the medicine in her body to help to facilitate. So I found her a vape pen and she was able to take, you know, 1 puff off of it, and it's enough to alleviate the nausea and from the chemotherapy to be able to then take her medicine.